Good evening and happy Teach Me Tuesday. I'm coming to you from my hotel room in California. I am here at the NAN conference, which I had a lot of fun at some of the sessions today. And tomorrow I'm going to be doing a poster presentation about simulation in the NICU and then some more good sessions and overall just having a great time. So always go to a conference. They're so much fun. But today we're going to talk about neonatal abstinence syndrome and how we can really work together to watch these signs and symptoms to support the family baby dyad. So that is our topic today. So let's start with a review. So as you know, neonatal abstinence syndrome is a group of clinical symptoms that present when a baby is exposed to opioid drugs for a length of time. It's now often referred to as NOWS, or neonatal opioid withdrawal syndrome. The NAS categories seem to be like kind of almost too broad, like we were putting babies in there that were maybe exposed to methamphetamines or SSRIs or benzodiazepines, like other medications, and they were having some of these withdrawal symptoms. So now we're able to kind of like separate those two so that we can really help those babies with opioid exposure. As many of you know, taking care of them is heartbreaking, but if done right and done well, we can get these babies home with their families sooner than ever before. So let's just look at some of those different substances that we see the baby affected by. So SSRIs, at the facility that I work at, that is considered a high-risk delivery. So our providers attend those deliveries. Initially, the babies will have apnea or respiratory distress immediately following delivery, and that is why our providers go to the delivery. The babies can also be seen in the NICU afterwards, either being treated for that respiratory distress, usually just some temporary CPAP, or from jitteriness and all of those other things that come along with that. So those benzos, those drugs such as Ativan, those symptoms can take up to 2 weeks for the baby to really experience. So they can have hyperactivity, hyperreflexia, poor feedings. But then we have our opioids. So as we know, those are the oxys, the morphine, the fentanyl, which is everywhere these days. Those symptoms usually occur within hours or days of birth. You know those symptoms. Those are the babies we all picture when we think of our NAS babies. The excessive crying, the poor feeding, the jitteriness, the butt breakdown, the sweating, the mottling, the sneezing, all of those things. But this is the substance that we really are focused on when we think of babies that are experiencing NAS or NOWS. I think what's important to see here is just that there are different drugs. And so if you're taking many of those drugs, which is called polypharmacy, that the baby can be having more increased withdrawal symptoms and they can be more severe. The more things that the baby is exposed to, the more likelihood that they are going to have a worse withdrawal. So how come some babies have like a terrible withdrawal and some babies are just fine? So it all depends on the amount of the substance that's transferred to the baby. So newborns who have chronic in utero exposure, we always talk about my favorite thing, right? The placenta, the baby. And the thing that combines them is that cord. So when we cut that cord and we take away that blood supply from the baby, we're also causing an abrupt stop to the transfer of the substance. So that combined with the low molecular weight, the lipid solubility, that's why it's been passing from the mom to the baby during this pregnancy. So that also is going to affect how the baby responds, what the severity of their symptoms is. So that's the amount and the purity of the substance, polypharmacy, the length of use, and then the mom and baby metabolism. So what body systems? We're going to talk about this a little bit more, but really when you think about this, we think of that jittery, hyperactive baby, but it's affecting many different parts of them. I think one thing that we don't always kind of like cue into is even respiratory, right? We do remember, those of us who used to use the Finnegan scoring system, that tachypnea was one of the scores, but it can also be that they're tachypnic if they're premature or if they had a meconium stain delivery, whatever those things that are coming together might be. But these babies are going to have neurological symptoms, gastrointestinal, respiratory, autonomic, their skin, many things are going on here. So what do those symptoms look like? So here we are, our tremors, our hypertonia, the vomiting, the watery stool, the irritability, the diaper rash. I almost like don't even want to call it diaper rash because it is skin breakdown. It's the acidity of their stool caused from the hypermobility of the stomach during the withdrawal that is causing this severe breakdown on their butt. It's almost like a wound from the acid. When you think of diaper rash, right, you're thinking of that baby that maybe has like a little redness. Like this is usually much more severe than that. If you've never participated in the Finnegan withdrawal system, which is how we used to score the babies, all of these were on there. So if you kind of think about those things we used to score them for: modeling, sweating, fever, tremors, hypertonia, tremors at rest, tremors when stimulated. All of that comes into these factors that the babies that have NAS, more specifically NOWS, right, neonatal opioid withdrawal syndrome, are going to be experiencing. So that's a lot. It's a lot for you to take care of, but mostly it is a lot for those parents who are going to be taking care of the baby while in the NICU, but also at home. It's really important to remember that these symptoms are not completely resolved when the baby goes home. The baby still may be experiencing some of these things, such as the tremors or the jitteriness or the excessive crying, the non-nutritive sucking that they're doing on that pacifier, that excessive suck that they may have. All of those things don't just like disappear. Oh, you're 1 week old, you're fine. So it's so important that when these symptoms are happening, that we are engaging with our parents as part of our care team. So how can we best help the baby? So the number one thing we can do is non-pharmacological treatment, right? It's easy, it's free, it's something we can teach to both the parents or any of their caregiving team that's going to come in and help them with their baby. So if we break those down into categories, right? In the room, we have dim lighting, low temperatures. Like these are those rooms that are cold, especially in the middle of the night. We're using our calming voices, our quiet voices. We might play those white noises in the background that would be soothing to the baby. Then we have our caregiver consoling. So that can be the bedside nurse, the provider, the therapist, but mostly we want to think about those primary caregivers, the mom, the dad, the foster parents, whoever it might be that are going to be taking these babies home, to really teach them how to best console these babies. So that's swaddling, right? Swaddling is the number one non-pharmacological intervention. And that's because we can do it for everyone. It would be amazing if our number one non-pharmacological intervention was breast milk and skin to skin, but we can't always do that, right? Maybe there's mom and baby have been separated because of delivery. Maybe mom is choosing not to provide milk or cannot provide milk, but swaddling is really something we can do for everyone. We want to remember that firm touch, not the stroking. The non-nutritive sucking, having a pacifier available. Massage, music, light music in the room. Even that idea of, trying to get to the baby before they escalate to the point where we cannot regroup them. So noticing those subtle cues of the baby starting to wake up and approaching them before they do. Other considerations or orders that you may ask for from your provider. We definitely need a skin barrier. So we have skin breakdown not only on the butt, it can be on the hand, right? If the baby's excessively trying to suck on their hand. If they are moving their head back and forth, it could be on the back of their head, their elbows, their heels, those areas where the kind of constant rubbing would be playing in there. We need maybe low volume, frequent feeds, and in that case, we might need to increase their calories. So many reasons this could be happening. The vomiting, the diarrhea, or just all the motion of the babies. They're at very high risk of losing weight. So we need to make sure we're giving them enough calories to compensate for the movement that they're doing. Making sure they're dressed in soft clothes, soft blankets, things that are not going to be irritating to them. So now we get into our pharmacological treatment of NAS. So our primary defense is morphine. Remember, in the treatment of NAS, morphine's mechanism of action is that it decreases neuronal activity, causing less severe withdrawal symptoms. So how I like to think of this is you have these neurons, right? So remember, NAS or NOWS is a symptom of the neurological system, right? This is a diagnosis of the neurological system. We've had these neurons that are used to receiving something, right? They've been used, the opioid receptors have been used to getting opioids in there. All of a sudden they're not. So they're kind of like, where is it? Where is it? Where is it? Where is it going? Where is it going? So what morphine's doing is it's just saying, hey, we're going to kind of quiet you down. We're going to decrease the neuronal activity, and it's going to decrease the symptoms. The morphine is not going to quiet the brain and rid the baby of all of the symptoms. It's just going to quiet it down enough that the baby can have a recovery from this withdrawal. There are different approaches to scoring the babies and the treatment of it, but with the Eat, Sleep, Console method, which is the evidence-based practice adopted by many units out there in the world, you are starting with that flat dosing. So we're giving them a simple, straightforward dose, PRN, and then it might need to be scheduled, and then you might need to go to weight-based dosing, either on a PRN or a Q30 schedule. So those things together is kind of these safe dosings that we're giving. An adjunct therapy is clonidine, right? So when you think of clonidine, you probably think, is this a blood pressure medication? I swear I've always given clonidine for blood pressure. Oh, sorry. And with clonidine, you are, okay, it's not going to go back. With clonidine, the goal is, again, that we're just kind of relaxing that system, kind of like how it would be working to decrease your blood pressure. It's just a relaxer, and it's helping the baby to be calm and to, again, on the neurons, because this is a neurological disease. Clonidine could also be used as an anti-anxiety. So same kind of idea, is that it's just it's a system quieter. So what does parental support look like, right? It's the single most important thing we can do for our babies with NAS, is to get the parents into the bedside. So having 24 hours accommodations, private rooms, or a room where they can be private, using your peds or floor instead of maybe the NICU, so that they have a room that has a place to shower and a bathroom. Having meals or snacks provided so that they have an opportunity to eat throughout the day. To support breastfeeding those moms who desire to and are safe to. Getting those babies on skin to skin. There's nothing more bonding than having your baby on your chest, and this is so important for our parents whose babies are experiencing NAS. Having that support person. As you know, it is very tricky to take care of a baby like this, and the parents are in there, and we want them to be in there all the time. So really having them identify not only someone that's going to support them while they're in the NICU, but while they are at home, so that they can have the opportunity to take those breaks. And really, again, educating the parents on that early intervention to make sure that there isn't this huge escalation. And then we want to prepare our parents for discharge. What can they expect at home? What does mixing high-calorie formula look like? What should the symptoms be looking like? When should we see some resolve in them? That's going to help them to identify what's going to come next. So in recapping, every 15 minutes a baby is born with NAS. It's a wild statistic, and I feel like that time is just getting shorter. 60 to 80% of these babies will exhibit those symptoms that we've talking about. Supporting the family as a caregiving team will help the baby to recover faster, to go home sooner, and the family's going to be better prepared. If they've been at the bedside participating in care, seeing how to keep their baby from escalating, they're going to be very successful at home, and that's all that we can hope for all of our babies. So thank you for joining me today on this Teach Me Tuesday. I hope you'll have a wonderful day, and I will see you next week.